Well, I appreciate all of you coming back for a second round and for doing it on a Friday afternoon slash evening. So we appreciate that. Dr. Lau and I went through all of the questions and we were really surprised at how wide they were, you know, in breadth, and then also just how good they were. There was one theme that came out though, and that was that the classifications and the diagnosis and the documentation was a little bit, we needed to really address that. And so the very first part of this is going to be Dr. Lau just going over the classifications so that we're all on the same footing when we go forward with the rest of the questions. So I'm going to go ahead and advance, and Dr. Lau will tell me when I can advance the slides, but I'm going to let him take it away for a little bit.
Great. Well, thank you, Teresa. As Teresa and I both go into practices, one of the areas I think that is, I know we can clear up on this session is basically how the classification is related to the reimbursement. And she and I both, we did a little prelim promptu for this, and we both agreed that one of the issues that occurs is that what you may be seeing is not necessarily what the third-party reviewer is seeing. So you have to almost be overly critical of yourself in getting documentation, because you may be thinking you're seeing it, but that's what we always talk about third party. First party is the patient, second party is the clinician, and the third party is someone else. So everything that you're seeing has to be very clear for that reviewer if you're going to get the appropriate reimbursement. Teresa will again go over one of her favorite topics called the appeal, but we want to have as few appeals as we can, right, Teresa? I would hope that that would be the situation for us. So, in my mind, and again, being a periodontist, I don't want to overly simplify this for you, but I only know about 4 groupings of every single patient that could be in your practice. And those 4 groupings, I sort of call them buckets. And if you look at the population, and also if you look at CDC numbers, we are told that about 47%, give or take, have tooth loss periodontitis, bone loss periodontitis. If that's the case, our first bucket is a big bucket, and it's the gingivitis bucket, and we'll talk about the prophylaxis in that bucket. The next bucket is considered to be the early periodontitis bucket. It runs probably 10 or 15%. Most of the periodontitis we find, according to the CDC report, is in that moderate periodontitis bucket, leaving the last bucket for severe periodontitis. Now, I'm going to have a conversation with you later on, because if you think about this, gingivitis early, moderate, and severe was sort of predating even what we consider to be chronic and aggressive periodontitis, which, by the way, third party never really jumped on. And you'll see as we go into our next phase of our AAP classification, which is the staging and the grading, and we want to chat with you a little bit about that. So if you take a look at that second bucket, which is the early periodontitis, the pocket depths are generally 4 to 5 millimeters, possibly 6. The bone loss is less than 20%. But I want you, and again, Teresa stressed this, and I'm going to stress it to you too. If you look at this mandibular first molar and you look at the mesial, even though there appears to be bone loss when you look at the CEJ to the bone level, that is considered to be normality. I think one of the areas that we forget is the bone. The bone does not come to the CEJ unless there's passive or active eruption. So what you see on the distal of this tooth is actually normal. And if you were to send this in, I'm sure that Teresa would agree, you're going to get denied. So if you look on the mesial of this tooth, now we're talking. So now, even though you may think that that is, Sam, that can't be just slight bone loss. Oh, yes, it is. When you look at reimbursement and what most third parties are looking at. So if we could go to the moderate one, you know, on the moderate one, now you're looking at 5 to 6 millimeters or slightly greater. You're starting to see a little furcation in that mandibular first molar. The bone loss is now between 20 and 50%. That little furcation area that you see, that's what we usually call the apex of the furcation area. Now we're getting a sort of to a furcation 1. I'm sort of leaving mobility out of this at this point, because for the most part, reimbursement entities probably could care less about mobility. Me as a periodontist, I care a heck of a lot about mobility. So when we look at our last bucket of the severe, now we've got greater than 6 millimeters. The bone loss is greater than 50%, and absolutely, just because of attachment loss, you're going to start to see at least a class 1 plus or 2 furcation, or possibly, in this case, probably this is a 3. You know, Teresa also mentioned something that I know is not going to be easy for you. There was a time when I think pocket depths and radiographs were just about all you need. But what I'm sensing is this thing of clinical attachment loss is becoming more and more and more for your documentation. You know, I feel for you, because measuring clinical attachment loss, measuring pocket depths is hard enough, but measuring clinical attachment loss is not easy, especially when you have restorations. But I would suggest to you, it's time to start looking at that as we look at, in addition to radiographs and pocket depths. So if you take a look at the classification systems, I don't know how long it's going to take for third party to really adopt these. In fact, if you don't mind, I'd kind of throw it back to you, Teresa. I mean, what's on the horizon? Because you've got your ear to the ground more than I do on this.
Yeah. So I've been to 3 different insurance conferences in the last, I'd say, year and a half, and they all had speakers on this topic, and it was discussed. And some of the larger ones, the Aetnas and the Cignas, did talk about incorporating the staging and the grading into their benefits. This year, I was looking for that in the documentation, and I haven't seen it yet, but I'm going to bet that 2021 benefit booklets are going to have references to the staging and grading.
So we're going to preempt them all, and again, at the end, Teresa and I both are going to give you our emails. If you want more information on this, I have a webinar or series that I can send you. But in the 2018 classification, this is where the American Academy and the European Federation of Perio got together and spent an inordinate amount of time to come up with these 4 buckets. Now, these 4 buckets are different from my 4 buckets. These 4 buckets are, the first bucket is periodontal health with some gingival diseases, biofilm-induced, true periodontitis, and those would be the early, moderate, and severe. And then they have the periodontal manifestations, which I think some of you wanted, which is mucogingival deformities, traumatic occlusal forces are close to my heart. And then finally, they put in something about perio-implant diseases and conditions, which is so important to us now. So if you look at that, let's look at staging. So with that, in periodontitis staging, now this really looks at the clinical aspect. The interdental clinical attachment loss, you see stage 1, stage 2, stage 3, stage 4. Now, you and I have got to figure out how to put those 3 stages of SAM, the early, moderate, severe, into these 4 stages. And you see RBL, which is the radiographic bone loss, coronal third. Stage 1, almost stage 2, is SAM's early. Stage 2 to stage 3 is Sam's moderate. Stage 3 to stage 4, absolutely stage 4, is going to be Sam's severe. So as you do this, it's not too far off of what I'm suggesting to you, but at this point, I would go with gingivitis, early, moderate, and severe. You still cannot lose with those. Now, what's happened in addition to this is something called grading. Now, in grading, there is, for the first time, a situation of now looking at something that should have been doing for years. And this is the perio of Canberra. This is risk. So when you look at all of these, both staging and grading, there are two things you got to have, and they have to be perfect. One is radiographs. Now look at the top. Now, if you think Delta is going to be able to reimburse you, and Teresa's laughing, if you think Delta is going to be able to reimburse you with what you see at the top, which is what I ever now and then see as a periodontist, it ain't going to happen. Now, what you see on the bottom is the very same patient where we had to retake the radiographs. Now, I don't have to tell you about what that takes relative to a patient when you retake radiographs, you know, because I just read the article on I'm going to get a brain tumor for all the radiation I'm getting. But my favorite radiograph, and it's not easy to do with sensors, is going to be the vertical bite wing. But you see, I decided years ago to go to phosphor plates. It doesn't matter to me what you use, but if you can't really see the bone loss, don't think they're going to see it. And then on the other side, the second most favorite is you've got to have a chart that Teresa was explained to us very, very well. This is, I'm partial to it because I'm part of VoiceWorks. I helped create VoiceWorks, but that's the kind of chart that you get with the graphics. So on our next slide, you will see what we mean by the establishing the stage. And I've gone through that with you from stage 2 to stage 4. As we move forward, then you'll see establish the grade. Now with the grade, you'll notice now this is a little bit of an interesting way of calculating the bone loss, but really what they're trying to get is it progressive? Grading is it progressive, and what is the risk? And this is where you get into this whole arena of periodontitis is not really about diagnosis except for maybe third party. What's really critical here is prognosis. And so this sort of gives you that. By the way, there's something out there called Previsor. I will tell you that some of the deltas are already using Previsor as a risk assessment, Previsor, and it's actually free. So if you're really looking for caries risk, perio risk, and oral oncology risk, check out Previsor this weekend and do the demo for you. So with our next slide, so here's your grading. And if you're grading, you'll notice, see the progression. You've got grade A, slow rate, grade B, moderate rate, grade C, a rapid rate. So naturally, if you look at grade C, you and I both know that that's where that aggressive periodontitis is going to be. The rapidly advancing perio, the refractory perio, the preperiodontal perio possibly. That what you used to call maybe generalized juvenile periodontitis. So now you see that it is staging and grading is where we are. So next with us, we talked a little bit about perio from the standpoint. I want to reinforce with you about these codes if you're in the United States. And again, reinforce with you that if you're going to use anything, whether it be a blade, a laser, doesn't matter to me, on the phase 2 surgical, that there you're going to really want to use 4260 and 61, which means the flap must be elevated so that you can see the osseous, the bone, so that you can work on the bone. By the way, you may, well, I'm sure you're very aware that practices are starting to somewhat become retail centers. This is not unusual. You see it in the veterinary market when you're sitting there between IMs and hills. You see it if you've been to a dermatologist or a plastic surgeon. You've seen the glass enclosed cabinet with everything you can think of. But also, please appreciate that some of us are moving towards a retail center within our practice. And that's where Teresa has put in that home care medicaments, that D9630. The ones that we use are probiotics. We're very much into Probiora. If you don't know Probiora, you need to take a look at it, Probira, scientifically based probiotic. And then we also use anti-inflammatory gels for everything we do for surgical, and the gels that we use is Perioscience, P-E-R-I-O science. So, Teresa.
All right. So we had a lot of really good questions yesterday. And so let's build on what Sam has laid the groundwork for. And we'll go over the questions that we received. And also there's a couple things that I knew were going to come up. And so we'll slide that into this as well. So what you'll see on the screen are the questions that we received. And then I'm going to, of course, give you the answers. They're my best answer. Sam will pipe in when you have these clinical questions. And I apologize, I meant to call you Dr. Lau. I need to be professional on these webinars, right?
Yeah.
One of the questions that I got, and I'm glad she asked this, or the person asked this, because it gives me a chance to clear the air. I never want to advise you to do anything that's not in the patient's best interest. The question was, are you advocating for exposing patients to additional radiation solely for insurance reimbursement? Absolutely not. Absolutely not. What I would hope that you would do is, in the beginning, when you gather all of the diagnostic information, that you would have adequate radiographs to move forward. Now, if you are in a situation where you want to track the progress of healing, then it makes sense to take that radiograph in order to track the healing, and you'll have, your baseline. The reality is, though, that there are times when the radiographs that we take are just not good enough. Whether that's the staff, whether the machine was having a bad day, whatever it is. If you look at the radiograph and realize that it's one of the radiographs that Dr. Lau put up that just would not be acceptable, do you have to think about taking another one? And you would ask the patient, look, it looks like we did not get a good picture. I'd love to get another one, and just want to let you know that, we'll have to do it. It'll be complimentary. And if the patient agrees to it, that's fine. So I'm not advocating getting the extra radiation. What I want is for you to get it right the first time and make sure that it's a really good legible radiograph. And yeah, so I hope that didn't come across that I was just saying, hey, take this and take that just so we can get paid. The benefits will either be there or not. The relationship with the patient will be what is going to move the treatment forward. Let's go on to some other ones. So the next question is, in our office, the x-ray should be within 12 months. So 24 months is okay too. And the reason the 24 months came up for the people who are just joining us tonight is that I said the radiographs that the insurance carriers are looking at need to be at least within 24 months. They need to be recent, because their hands are tied. When they look at the benefits, they actually can't approve benefits unless the radiographs are recent, and some are even saying 15 to 18 months. So one problem that I had with this question, though, and it goes into that whole way of thinking where we need to not treat every patient as uniformly as we can. I understand that it just makes sense for once a year to take bite wings on everybody. But if you take a look at the radiographic guidelines that the FDA and the ADA have worked on, radiographs are prescribed. They're prescribed to an individual. So if you have a rule in your office that states bite wings every 12 months, and that's across the board, that's not really ideal. So you can Google those radiographic guidelines. Just put in FDA, ADA radiographic guidelines. It's a PDF that'll pop right up. If you need to, you can certainly, our emails will be at the end, you can email me and I'll send it to you. But you should be looking at individualizing the radiographic frequencies due to the patient's condition. So, I mean, we all know some people have great teeth and really only need radiographs maybe once every 2 years. I mean, you would feel comfortable about that. I'm not the clinician you are. You would be able to make that decision. So 24 months is okay too, yes, but I would rather you have an x-ray that is perfect for you to make the decision you need to make today. You know, one interesting thing when Dr. Lau was talking about third parties, the third party that we don't think about and we absolutely should is the state board and also the lawyers. So although and I don't want to scare you, but when you go to make your classifications, your stages on your first visit, when you look at which bucket you want to put them in, the reason I want you to think about that third party is because if you were ever to go in front of a judge or a jury of your peers, that's one of the criteria they're going to use when looking at your case. So always document to the level of what your malpractice lawyer would be happy with. That's another rule that I have with my clients when I was consulting. I would always say, would this stand up in court? And they would just look at me and we knew we had work to do, right? So, okay, so let's move on to, we're finding that gross debridements are not being paid. How should they be presented to insurance in order to be paid? Should we send intraoral images? Well, with debridement, if I see a picture of a mouth that needs debridement, I would write you a check right away because it's so evident. Debridement is visually, that's an intraoral image dream right there. So yes, you don't have accurate readings, so because you need to take care of it first, so you wouldn't send those. Radiographs really wouldn't help either because you're going to have a lot of just stuff on there. So yes, intraoral images is what I would take, and I would also, in your medical history, I would make a note from your medical history, I'd make a note in your clinical record just how long it's been and any complaints that the patient presents with. So again, put it in your clinical record, take that snapshot and send it in. Now, debridements, I have found that I don't need to really appeal those as much because either the plan covers it or it doesn't. So, you know, if it doesn't, it's most likely because there's just no benefit for it. I would appeal, if you want to appeal, I would send it in and ask them for the alternate benefit of a 1110. Now, what I mean by that is you're not changing the code. You're still sending in the 4355, but what you're doing is you're asking for the benefit of the pro fee. So you're not saying you did a pro fee, you're just asking if benefits can be taken from this for that. Now, the other code that I'll tell you about that you could also do that with is 4910. So if you run into frequency limitations for your periodontal maintenances, what I've been teaching for years is to ask for the alternate benefit of the 1110, the pro fee, and see if you could at least recover some funds from the carrier for that. It is really 50-50 as far as success, you know, for myself and also from what I'm hearing from people. So it could work, it could not work, but what you did is you went to bat for the patient, and that's the important thing. All right, so here is, and this is, I do want Dr. Lau to talk about this part, and this is the transfer of the protein bacteria. I have been informed in the past that you cannot transfer the protein bacteria from pocket to pocket as you are probing. Do you have research on that? And that is because I said last night, I was trying to explain it to the non-clinicians that the perio probe, when you move it from site to site, would have some microbes on there. And I'll let you handle that one, Dr. Lau.
Well, there's no doubt, and it would be naive to think that if you dip a periodontal probe in a sea of gram-negative anaerobic organisms, and then take that same probe and go into a very healthy pocket, that you're not moving bacteria from the periodontal pocket into a more healthy sulcus. But the good part for all of us is, and studies have been done, is that the bacteria will only stay there if the pocket has a architecture to allow them to grow. In other words, an architecture similar to the pocket they came from. So you're not going to get those organisms that are going to be able to colonize in shallow, healthy pockets. First of all, there's not enough gingival curricular fluid for them to live off of. So generally they will not colonize. Please understand that the presence of bacteria is not what we consider to be characteristic of a particular periodontal disease. It is the colonization of those organisms, probably up to 4 to 6 weeks minimum, before we can detect them as far as them creating an inflammatory response.
So for my non-clinicians out there, one thing that I want to urge you to do is, if you're not sure what some of the words were that Dr. Lau said, crevicular flow and all of that, what I would do is talk to your doctor and see if your doctor can explain it. I was blessed to have a doctor that explained everything to me, everything he was doing, why, what, everything when I was an assistant. And that's how this curiosity for the clinical has come about. So don't be afraid to go and ask your doctor and your hygienist to explain some of these terms. That's just going to make you a better insurance coordinator. So let's move to the next bullet point. I don't understand why you make the difference between a comprehensive exam and a periodontal evaluation. When I first see the patient, a comprehensive evaluation is done, which includes an evaluation of all periodontal parameters. Can you explain this? Yes, absolutely. So the two initial evaluations that we have in the code book for our disposal is the comprehensive and the periodontal. So that's 150 and 180. And what I had said in the course is that many of you, if you're dealing with someone who has you're staging them and they have periodontal disease, you are most likely doing a 180, not a 150. So what I put here was the actual definition of 180. And so if you look at the code definition, it really says to me that if you're dealing with someone who has risk factors, someone who has signs and symptoms of periodontal disease, and it also includes all of the other stuff that you do as well, the charting, the evaluation, recording of the patient's dental and medical history, and general health assessment. So, and it includes, I mean, you can read it, it includes all of the other evaluation points that you would make in your comprehensive evaluation. So 180 clearly does say that it's meant for patients who are in one of the buckets that we talked about, because you are most likely going to go forward with periodontal treatment, and you're also going to be talking to them at length about the periodontal risk. So I appreciate that I was able to clarify that. Now here's some carrier questions, and so for my clinicians out there, you're probably gonna, eyes are gonna roll in the back of your head, but let's go through it anyways. So when you use 4346, the insurance takes out the deductible, and this is the scaling in the presence of inflammation. So the Prophy code has actually paid better with no deductible. I love the Prophy code paying better. I love that it pays more, but if you have to use the code 4346, then what you have just done is taken that patient temporarily out of that healthy classification. So Prophy is not appropriate. Even though it pays better, it's just not appropriate. Now, again, I'm not a clinician, so at some point, could you bring a 4346 person in and they don't need that anymore and it is a 1110? Probably, absolutely, right? So in that case, then you would do 1110. But if the patient presents with that inflammation and it's generalized, even though 1110 pays better, it's just not appropriate. So I get it, I'm tempted to, but we have to do this. So. And then the next question was 4346, can it be used multiple times or in consecutive visits? There is no language in the code that says you cannot use it multiple times. Now, the benefit booklets will usually say if there's a frequency, and I've scanned a couple of them. You know, I'm the insurance nerd. I like to read these booklets, and I don't really see a lot of frequencies built in for 4346 right now. Now, what I have learned from working with carriers for a long time is that frequency limitations tend to evolve, and I definitely see as 4346 because it's still a relatively new code. As its usage goes up, I suspect you're going to see more frequency limitations on it. But for right now, according to the ADA, there's really nothing in there about it. I would just hope your patient would get somewhere other than just being always constantly inflamed. So here's another one. Can we bill 4910 4 times a year instead of 1110 if it's an insurance benefit for my patient and they pay more than 1110? You can bill the 4910 4, 5, 6 times a year if you see them for 6 visits. If it's what you did, then you should bill for it. And I don't want you to worry I know, listen to me before you go, wait a second, I have to worry. I don't want you to worry about the carrier benefits. What I want you to think about first is this is what's best for the patient. And we do need to let them know that, right? So if the insurance carrier doesn't pay for it, it doesn't mean that you don't do it. It means that the patient's going to have to think about whether or not they're going to commit to that financial, commitment there. And that, unfortunately, that's the patient's decision. So you could do 4910 4 times a year if you decide that they need to be at a 3-month interval. Many of you do see them for 3-month intervals, so absolutely you could. The carriers typically do benefit twice a year and sometimes 3 times a year if there's extenuating circumstances. Some of the carriers actually benefit extra if you have a condition and you let them know in the notes that they have an ongoing condition, and you could do it in an appeal. So that could be something to try. But again, I would always warn the patient that there's the possibility they're not going to cover it. And so how will we take care of it afterwards? Okay. I don't understand why insurance recommends you alternate 3-month recare codes with the prophy and perio maintenance for coverage. It does not feel ethical. So if I could fist bump you through the camera, I would, because I don't understand why they do that either. And I've talked to multiple carrier representatives at the higher level, and I've said, look, I've been on calls. Your carrier, your service representatives are telling me to alternate the codes. And they say, well, that's not what they're supposed to say. So there is a disconnect there. I've heard it myself. I know you have. You do what you are supposed to do, which is bill it correctly. It's not ethical to do an alternate 1110 and 4910 if that's not what your clinical record indicates. So absolutely make sure that you are always billing for what you actually do. Okay, after local scaling and root planing, which is 4342, that's the 1 to 3 teeth or 1 to 3 sites, do you recommend putting a patient in a perio program or back to 1110? And this is when I realize my limit and I go to my clinician here, Dr. Lau.
I always have suggested to every office I've ever been in, never use the word fix, never use the word treat when it comes to a chronic inflammatory disease as perio. So therefore, can you cure diabetes? Let's say you have type 2 diabetes. Now you're exercising, running marathons, you're eating fantastic, you got your blood sugar within normality. Does that mean that you are healthy for the rest of your life? No. It still means that you're predisposed to a diagnosis of diabetes. Once you have perio, always perio.
So I will give you one other tip with 4910. When you present the treatment plan for scaling and root planing, osteosurgery, whatever treatment you decide for the periodontal treatment, I would add on the bottom of the treatment plan, I would add 3 to 4 4910 line items, because what you're doing is you're reminding yourself to go over that with the patient, that when they come back, it is no longer going to be the regular cleaning that they're used to. I know those terms make me shiver too, but it's not what they're used to. So putting that on the bottom of their treatment plan reminds you to talk about it and also lets them know there is going to be additional costs. So that's a little trick that I would absolutely start using. So here's a narrative that I'm happy to share with you. And a lot of times I forget to tell people about the book. I know David did as well, but the book that I wrote, Moving Your Patients to Yes, does have information like this in there. It has scripts. It has some sample narratives in there. So if you're looking to talk insurance and that really gets you excited, that is the book for you. So these are narratives that I would send in if you're trying to get 4910 covered. So please apply the alternate benefit of 1110 for this procedure. Patient understands that 4910 may not be paid, but has asked if payment for a prophy could be applied. And then the bottom one, you can see I'm giving a lot more information. Patient still has active disease. This is where if you have the staging and grading set up and you're actively using it, this is where the grading comes in perfectly. And I can use that to say, look, we're still treating this condition. So the reason why I have the 24 months up there is because many of the carriers actually say they're only going to pay for 4910 for 24 months. And I have had almost 100% success appealing that because I can always show that there's still active disease. Okay, So here are some clinical questions here, and they have to do with the LBR, and we talked a little bit about using the laser for aphthous ulcers, the herpetic lesions. So we're going to go into that. So Dr. Lau, placing hydrogen peroxide into the pocket for LBR was discussed. Can you discuss this a little bit more?
Well, diode lasers naturally are going to look for targets chromophores. We did talk about the gram-negative anaerobe Porphyromonas gingivalis being pigmented. But what we're also finding is possibly using dyes. Those are called photodynamic therapy. And recently, there has been some activity with putting just hydrogen peroxide in a sulcus and then taking your diode tip 1 millimeter into the sulcus, so that now you're activating the hydrogen peroxide. And again, I'll give you my email if you want to know more about that. I can send you the study. You went to a court where the speaker said, no, never go above 1 watt. That totally depends upon your state and whether you can do curettage or not. Also, 1 watt is different for continuous versus when you're thinking about pulsed. Now, going above 1 watt on continuous, I would agree with, because then you're going to fry the gingiva. But going 1 watt over 1 watt on pulsed, that's a whole different situation. So again, I go back to what laser are you using, and again, what are you trying to do? So another periodontist told you not to treat those herpetic lesions because of the aerosol. It will get into my eye. Well, if you're wearing protective goggles, I can't imagine that happening. I have the Biolase diode. Would you like to use it? So what is your opinion on that? Always use a pre-rinse that we've talked about. We're starting to believe that the pre-rinse should be 30 to 60 seconds with hydrogen peroxide. That's number 1. And number 2, have high speed evacuation. And if you do that, it is basically impossible for that to happen.
Great. And if you could expand on what keeping a tip uninitiated means.
Sure, and this has to do with diodes. A tip that's uninitiated means it's not dark at the end. So that means that the energy completely comes out of the tip and looks for something black. If it is initiated, the energy sees the black and then heats the black, and that's how you get the curettage. So uninitiated for laser bacteria reduction, aphthous ulcers, herpetic lesions, and initiated for your curettage. Is there a code for biostimulation after surgery? No. You're looking at photobiomodulation, and unfortunately, there is no code. But as Teresa continues to tell us, don't let third party dictate what you do. Is the laser being used for bactericidal purposes or only for performing gingival curettage? It's being for both. For laser-bacteria reduction, is strictly bacterial. For curettage, it's actually bactericidal and degranulation, which I think is very important. Is the Porphyromonas gingivalis black or brown in the pocket or in the Petri dish? It is black or brown, both. Only though if your Petri dish has blood agar in it. If the Petri dish doesn't have any blood agar in it, then the organism will not consume into the cell walls. Is it possible to repeat the settings for LBR? Yes, but it depends upon your laser. Let me just give you, in general, uninitiated tip, 0.5 watts, continuous, or uninitiated tip, 1 watt, pulsed, 0.8 to 1 watt pulsed. When you do LBR, that depends upon you. If you're looking at bacteremia, naturally, you would do it beforehand. And can you use LBR and Arrestin on the same day? Absolutely. The local delivery antimicrobial is going to probably sustain what you did with the LBR.
Perfect. Okay. So here we go with some more billing questions. So if only one quadrant needs 4341, should we bill 1110 for the rest of the mouth because the rest of the mouth is healthy? there is a gap in the code, unfortunately, that does not take this into consideration. It was discussed at last year's Code Maintenance Committee, but not at this year. So I think we're still going to have that gap. You would do that because that's really the only alternative that you have, and make sure that your notes state that that one quadrant is not healthy, whereas the rest of them are in a good state. Can you bill them on the same day? You should, but should you expect reimbursement? Probably not. 4342 is probably not going to need to get reimbursed. 4341 will get reimbursed, but you'll probably see that they won't benefit the 1110. But I have seen it where they'll benefit it, and the 4341 in itself is paid. So it really is across the board. Important to note though, just bill it and see what happens, but always make sure the patient is aware that that's the situation, and even say to them, there's a gap in the code. I've tried my best. I've asked the experts, and unfortunately, this is really the only thing that we have available to us. So another question that, oh, I like that she says it may or may not be related. Is your hygienist only focusing on 1 to 3 teeth for the 4342 and not the whole quad? Absolutely. The code itself says for the 4342, 1 to 3 teeth or sites. And so yes, it's only a limited amount there. Now, oh, these two are for you. Yes, okay. Any extra precaution when using Epic X laser with this COVID-19 pandemic?
A question that I'm getting 10 or 15, 20 times a day. The Epic X laser is not going to produce an aerosol. It possibly can produce a plume. But again, I strongly ask you to do a pre-rinse. And if you do a 30 to 60 second, now I would suggest now 60-second pre-rinse with hydrogen peroxide or one of the products that are out there, like Perioxol from, I believe, Colgate, then I think that you're really, well, we know hydrogen peroxide actually kills the virus. And then if you turned around and put the hydrogen peroxide in this August, and you have high speed evacuation, then I would not have any precaution over what you were normally doing. You stated to state LBR at the beginning. Can you do it at the end? My friends, if it's a very healthy mouth that's not overtly inflamed, do it at the beginning. If it is a highly inflamed mouth, there is no reason why you would not do it at the end, especially in those particular inflamed sites.
Great. Okay, so 4 quads. This was interesting. We did get questions on 4 quads, and in my live lectures, I usually get about the same number because the same questions are asked. Now, 4 quads in 1 day, why not provide info in the narrative on the first submission? What's the advantage to waiting to appeal? I apologize if that came off wrong. I would like you to send it in initially with the first submission, because you're going to be sending in the radiographs and the periodontal charting and all of that. So yes, any of the extenuating circumstances we talked about, not stopping blood thinner, mobility is an issue, access to care, all of that. Make sure that that's in your documentation and your clinical notes so that we can present that in the beginning. And then the literature supports the treatment of 4 quads of PSRs or SRPs in 1 session. Why are those claims still denied? Does a consultant really look at this, or is this just processed by a non-clinical staff? I sense a good deal of frustration in this question, and I totally understand. I know the literature states that, but for some reason, years and years ago, the carriers began, and this is years ago, 20 years ago when I started, way back before then, they just decided that once one side, you just do one side, and then you do another side. And I really suspect that that's just how dentists fell in line. Now, I talk to dentists who say, I don't want to do 4 quads in one mouth. That's killer. The tongue is everywhere. All sorts of stuff goes on, and that's your decision as a clinician. I know the literature supports it, but there's lots of stuff that the literature supports that is not benefited. Just because it's not benefited doesn't mean you don't do what's right for the patient. So I feel your stress, I feel your pain, totally understand it. So now 4999, my 999 codes, is for full mouth, while laser-assisted periodontal therapy is for quads. So do you specify side and then bill again for the other side? Usually 49.99 can be done 2 times a year. So that frequency limitation, I actually haven't run into that much. So if you did submit this question, I'd love to know what carrier that is so I can make sure that I pass that on as well. I typically don't see a frequency, and really it's because they don't tend to benefit it anyways. So you could do it for the full mouth, and then if you do it again on the other side, so say you do the left side one day, I would do $49.99 for that day. Then the other day, the next day, I would do it for that day as well. It is in the code book. It does say that it's a full mouth. It's an oral cavity code, which means it's the full mouth. There's no teeth involved. But your report, your narrative is what's going to indicate the area. So don't get hung up on the full mouth part. I really have never seen them say, hey, no, it's a full mouth and you're talking about one tooth. Never ever had that happen. So don't get hung up on that. So if asking for the schedule or time spent, what's the amount of time they are seeking? 30, 40, 50, 60 minutes. And I know this person that asked the question, so hi, Janet, and good to hear from you. Now, she's asking this because she wants to make sure that in her notes that she's writing down how long she's seeing the patient. If you go back and listen to Wednesday night and you weren't able to, you'll hear that I said sometimes they're asking for a copy of the schedule because there are bad apples out there who are submitting tons of quads, and it's just not humanly possible that they did 50 quads in one day, right? So that's why they would ask for a copy of the schedule. Whatever is indicated with your clinical decision, that's how long it should spend. So I can't say what they're looking for and I can't say what's appropriate, but as long as your records fit into that time period, obviously if you do full mouth and your records state that you only had them in the chair for 20 minutes, that is going to be a problem. So I don't have a set time, and I doubt they do too. I think they really are just taking a look at whether or not it's completely off kilter. So wouldn't worry about that. Now, I did state that sometimes for osteosurgery benefit, they do ask for a history of scaling and root planing. Does it have to be with the same company? No, absolutely not. These patients hop around from employer to employer, from plan to plan. You just need to document it. And of course, if you have a copy of their previous records, that's very helpful too. Absent that, you could always say patient stated that they had this done 10 years ago, 15 years ago, whatever it is they say. Make sure you put that in quotes in your documentation. So now, can laser-assisted periodontal therapy be bundled into the irrigation code per quad, and meaning that you irrigate with a medicament and use the laser? And this person has had some insurance-savvy patients that have told them that. So the irrigation code, as we know, is just typically not benefited more, but the irrigation code is pretty clear in that you are using a medicament to flush and irrigate the area. So my instinct is to say no to this. Dr. Lau, do you have a thought on that?
Yeah, I would say also the same, to be no. It would basically be bundled.
And then what kind of pre-treatment rinse do you recommend? And I think I heard you say hydrogen peroxide.
Yes, and Nathan is telling us that we have a substantial number of questions.
Okay, he's like, okay, wrap it up.
I think any more questions that we got are going to be what they're going to ask. So
let me cover this, because this was a big question, and I hope that this is something that we can kind of knock out, because this was a big question here. And then Nathan will get to you, because I know you're waiting in the wings here. If we know that insurance will not cover the procedure, then is it still necessary to have the patient sign the HIPAA form? And what is that HIPAA form? In your manual, you will see that there's a right to restrict disclosure form. And what that does is it allows you to bill the patient for a procedure, but the procedure would not be submitted to the insurance carrier. So we did go over that. I'm happy to send you a copy of it. However, you should have one in your HIPAA manual. And then I'm happy to send this to you too. Here is the language that you would use to talk to that patient, because you would really just be saying, sign this so we can charge you. And we have to put that a lot more delicately. So happy to send you this conversation. Let's go on here. We'll get to that later. I'll leave this up so you can read that. So Nathan, what do you have for us?
Well, Teresa, it's going to be David, so sorry to disappoint you there, but we have about 15 questions, none live so far, and I would suspect after a couple of questions, we're going to be right at the bell. So maybe won't have live this evening, but this is from Zaira Delgado. I apologize, Ms. Delgado, if I mispronounce your first name. So you guys talked about D4346. Insurance pays it as D1110. How can we appeal to insurance to pay more on it?
So what you may have run into is just a hard stop with the benefit plan. So some plans specifically state, and of course the employer chooses it, state that there is no benefit for 4346. It will be what we call mapped to a different code, and that's why you're seeing the 1110. So in my experience, I've tried to appeal that, believe me, and they don't budge on it because it's just a hard stop with that plan. And that is why you definitely need to let the patient know ahead of time that that is a possibility.
Thank you. And Sam, there's a bucket of questions about some of the products that you mentioned earlier. So perhaps at the end, you can just jump on and repeat about your rinses and things like that. So we'll put that aside for just a moment, please. This is from Rosalie Silvestri. I found recently submitting for surgical extraction plus bone allograft and membrane that 7210, 7953, 4266. 4266 is not covered. How do you get that covered?
I will be honest with you, it's usually not. I have zero luck with getting that covered. So I'm so sorry to give you that news.
Well, it's well-earned news regardless, right, Teresa? Thank you.
Yeah.
A couple more that should be fairly easy. From Kit Dangler, can you bill a limited oral exam on the same day as an F like Frank, M like Mary, D, FMD?
Yes, that's the full mouth debridement. And yes, I apologize. I should have told you that. 140 is absolutely the appropriate code to use should you decide to bill an evaluation. I've talked to a lot of doctors who say, I'm not going to bill that. I'm going to just do the 4355. But you did a limited evaluation to decide to do that. And I am always about billing and getting paid for what you do. I would absolutely bill that.
Excellent. You are going very quickly, Teresa. We might get 2 or 3 more in. Can we bill a comprehensive exam and a perio exam together?
No, they really are, they overlap quite well. I mean, you could send them in, but they're going to get, one's going to get denied. And I'm betting the 180 will get denied because usually the allowance on a 180 is higher. So you'll always get paid for the 150. But again, yeah, you can't do both because they do include, the period actually does include the comprehensive.
Perfect. Thank you, Teresa. This one has a little bit of detail to it. If needed more than 2 appointments, I'm reading verbatim, excuse me. If needed more than 2 appointments for 4346, do we submit 4346 each time or 4346 for first appointment and 1110 for second appointment? What is recommended for 4346?
So my suspicion is that it was just a lot for the hygienist to deal with and it was unexpected when they came in for their appointment. So you're doing a part 1 and a part 2. You could bill one the first day and one the second day. However, the treatment is for a generalized condition. So really you are treating a general area. I would not be personally comfortable with that. I would be comfortable with raising my fee to make it, you know, it's a more expensive procedure. I would be comfortable with that. And of course, letting the patient know. If you're PPO constricted, of course, I don't have much to tell you other than you would just make sure to let the patient know that there is probably going to be an out-of-pocket expense. I'm not comfortable doing the 1110 as the second appointment because you are just, they're not there yet. After the 4346, you typically have them come back and see if there's been any healing, and there's not been any healing at that second appointment. So I'm not comfortable with that.
Okay, thank you, Teresa. And this would be the last one. There's actually 2 separate questions, but they seem very similar. So this is from Don Mangal. I'm sorry if I'm pronouncing your name incorrectly. I am a PPO provider. Can I still bill for laser to insurance or ask patients to pay for it? And then second question, Teresa, because it is aligned, how exactly can you bill for LBR with a Pro-Fee or SRP? Do insurances cover laser procedures? And they seem sort of connected there. So I thought I'd put them both to you as the final question for the day.
You've got it. So Don, really what you're running into is the problem every laser dentist who participate runs into. We want to bill for that. It's extra work. We know it's extra work. It's extra material and you know, capital expense, right? So Unfortunately, the only code available to you for that is $49.99. There is no additional code available. There's actually only one laser code in the code guide and has nothing to do with what we're talking about at all. So unfortunately, remember how we talked about how the literature is there and it just hasn't caught up? This laser in general is a perfect example of that. The literature is there, the benefits have not caught up. So if you wanted to bill extra for that and believe that you should be paid for that, then the HIPAA form and the conversation I have on the screen is what you would want to do, and bill it out as a $49.99. You could bill it out without having them do this form, but what I suspect is going to happen is it's going to come back denied, and it's also going to be disallowed. So I will tell you that there is, BIOLASE has an incredible billing guide, and I'm just going to say because I wrote it, they have a billing guide for you if you would like a copy of that. I know Dr. Lau would be happy to send it to you, and it does cover these situations, kind of walks you through step by step with that. So we wrote it specifically for BIOLASE customers because they do run into this so often.
Excellent, Teresa. Thank you. It's been such a fast hour. It seemed more like 15 or 20 minutes, but I'm very pleased that you and Dr. Lau were able to get through almost all, by my view here, of the questions from Wednesday's session. So thank you for your diligence there. Dr. Lau, before we get to the closing information about CE, et cetera, there were several questions just about some of your rinses, et cetera, that you had mentioned earlier. Do you have a moment, doctor, just to repeat some of the brand names, et cetera, there for the audience?
Sure. For the probiotic, it is Probiora, P-R-O-B-I-O-R-A, Probiora. So if you go on Google and put in Probiora, you will see it. It's a small mint that has these scientifically based probiotics, and it's excellent. For the rinse that we used for post-surgical, we use Periosciences, and that is the AO ProVantage rinse. But if you just put in www.Perio then you'll get all the information that you want. I'm going to have Teresa talk for a moment about her podcast, and then I am we're both going to finish, and I'm going to send you or show you my email. If you email me, I will send you about the Probiora and the Periosciences. But moreover, if you have questions or if you request the billing guide that Teresa brought out, I will send you the billing guide relative to not just lasers, but a billing guide in general that she actually was our consultant with.
So just want to say real quick, I have a podcast. I'm going to zoom right through here. My most popular 2 episodes ever were when I covered the Delta Dental lawsuit, which we all know that was something interesting that dropped last year. And I did an overview of teledentistry. So here are our email addresses. And if you're looking for a copy of my book, it's on my website. It's also on Amazon. So feel free to look it up. I do think you'll have a lot with it. My teams that have read it really seem to enjoy it. So I hope you do too. But yeah, Dr. Lau is happy to email you that information. My email is there for you too. We are definitely here to help. So I'm glad that we spent some time together tonight. So